Hello everyone, how are you doing? My name is Imelda. Welcome to MEMP Digital. So, today we are going to talk about hypertension, elevated blood pressure, BP, some people call it BP. What is it? And what can we do about this? It could be systolic blood pressure can be elevated. For clinicians that are here, systolic is the one on top and the diastolic is the one below. Okay? What is the normal blood pressure? Normal blood pressure is less than 120/80. Anything higher than that, it could be pre-hypertension, stage 1 hypertension, or stage 2 hypertension, depending on the disease process, or even if the person doesn't have any kidney disease or diabetes. And I'm going to refer you to JNC8 for more details. So hypertension that's blood pressure, is very common. Worldwide, more than 1 billion people have high blood pressure. Some people know they have it, some people don't. In America, it's more than about 50 million people have high blood pressure. So what are the risk factors? By the way, hypertension is a silent killer. That's what we call it, silent killer. It's a chronic disease. Some people have it, they don't know until something bad happens, until they have a stroke, or they have heart failure, they start swelling up in the legs, and they go to the doctor and say, oh, you have heart failure, you've been having high blood pressure, you didn't know that, it wasn't managed. So it's good to know your status so you can manage what is going on with your body. So the risk for having high blood pressure can cause MI, which is heart attack, myocardial infarction, or a stroke, which is cardiovascular disease. That's when half of the body is paralyzed, or depends where it affects on the brain. Okay? And taking blood pressure medication, antihypertensive, does a great deal in reducing the risk of having stroke and cardiovascular death. That's heart attack. Okay? And you want to know patient history is very important. A patient comes to you and they have comorbidities, but they don't know they have high blood pressure. Like they have peripheral vascular disease, like their feet, they can't feel their feet sometimes, or they tell you it's numb, or they're having like burning, or they walk. When they walk, they have pain, intermittent claudication. That means they have pain while they're walking. They say, oh, I walk, whenever I walk, it hurts. It hurts. I feel like achy pain. That is peripheral vascular disease or arterial disease, So you want to know which one they have. Another thing is heart failure. Those are the histories that will alert you, oh, there's something else going on. Coronary artery disease, arteriosclerosis, dyslipidemia, too much fat content in the blood, chronic kidney disease, renal disease. Sometimes people have a chronic kidney disease and they have hypertension, because heart and kidney work together. And diabetes, sugar, that's what some people call it. Oh yeah, sugar. if you're here and you understand what I'm saying. So it's very important to know your status and history, patient history, comorbidities. Another thing is history. About history, smokers. People that are smoking, because it affects the artery, it affects the vessel, it causes your blood pressure to go up. It causes hypertension. So that is a big deal for people that smoke. So the goal is to encourage the person to quit smoking. It's very difficult, but it's doable. Okay? Increased sodium consumption. People that eat a lot of salt, it increases your blood pressure, because anywhere that's water, salt goes, or how they say it, water goes, sodium. Anywhere that sodium goes, water follows and it stays there. So too much salty food, like processed food, makes your blood pressure go up. Another is saturated fats, red meats. It's not a good thing. It's not a good thing. Caffeine, too much caffeine, energy drinks, illicit drugs, cocaine. It makes your blood pressure go up, and it can actually cause stroke. Cocaine, taking herb, some cough medicine, over-the-counter cough medicine can raise blood pressure. So before you order that anti-hypertensive, if you diagnose your patient with hypertension, and just make sure that they're not taking anything that could be making the blood pressure go up. You know what I mean? Another is, if you want to check blood pressure, just to make sure you have accurate diagnosis. For some reason my feet keep itching. If you have accurate, to make sure you have accurate diagnosis, you have to have the patient sit down for 5 minutes, rest for 5 minutes, settle the body, you know, then take the blood pressure 2 times, you know, and trend the blood pressure depending on your setting. I like to trend it for like 14 days if they're inpatient, you know what I mean, depending on the type of inpatient. Or you can tell the person, go home, document your blood pressure, take it every morning, check both sides, you know, document it, and then come back so we can look at the pattern of the blood pressure. And you want to check it to establish the pattern of their blood pressure before you diagnose them. And it has to be up consecutively, you know, it has to be high, elevated consecutively. And part of the physical assessment, part of your physical assessment is you check the neck when you're assessing for blood pressure. Anybody that you're suspecting hypertension, assess their neck for thyroid nodule. Check the thyroid, okay? Because sometimes when people have hyperthyroidism, you know the word they say, everything is up, running to the grave. When they have hyperthyroidism, they tend to have blood pressure. So you know, make sure they don't have a secondary hypertension, you know, because if you can take care of the disease or disease process, then you may be able to control the blood pressure. You know what I mean? Another is carotid bruit. Check the neck again. See the bruit. Make sure they don't have a bruit, because they may have bruit and they can put them at risk for stroke. Okay. Check the jugular vein, the neck again. You have to position them the right way when you do the assessment. They have to be laying on the bed. Then you check the jugular vein, you measure it. Do they have S3, ventricular gallop, while you're assessing them? Check the eye for retinopathy, papilledema. Do they have black spots in the eye, in the vision area, visual field? Avinikin is a marker of hypertension, you know, retinopathy. Do they have flame-shaped hemorrhage? That's what you find all these things when you do fundoscopy, you know, fundoscopic eye exam, you know. Do they have blurry vision all the time? They tell you, oh, I can't see, you know. You may want to look into that, see if there's anything else that is making them not to see, maybe blood hypertension, or it's already affected the eye, they have end organ damage. Lungs, you check for, listen for crackles. Do they have crackles? You check for when you listen to the heart, S3 heart sound. Do you hear S3 heart sound? That is that could be a sign of heart failure. Even though it can be benign, sometimes pregnant women may have S3 heart sound because of the position of the uterus. It pushes the heart and, you know, gives a benign S3. So if they're not pregnant, do they have S3 heart sound? Do they have S4 heart sound? You know, that is if they have S4, sometimes it's because of long-standing hypertension. Even though the old people may have it, older people, elderly may have S4 because of the heart, you know, the contraction, expansion, the stretch, you know, because they're older. I'm trying to find the word for it, but S4 heart sound, it's not a good sound to have if you have hypertension. It could be that they have left ventricular hypertrophy, which is a left organ end organ damage. Do they have murmur? Like we said, check for bruit. Listen for pulsation in the abdominal area around the umbilical. Do they have the AAA? Very dangerous. Do they have abdominal aortic aneurysm? Because that is a ticking time bomb right there. You know, if it's not caught on time, people die. Okay, check for PAD, like we said, peripheral arterial disease and peripheral vascular disease. While you are checking the abdomen, check for renal artery stenosis. Do they have like a bruit around in the kidney when you're listening, in the area, in the stomach? You hear a bruit? Oh, sorry, you hear a bruit. So check and make sure it's not a renal artery stenosis. Another is truncal obesity, or they call it purpose triad. You know what I'm talking about, endocrine disease. Sometimes when people have that, they can have hypertension, okay? Or do they have polycystic kidney disease? Do they have like edema, pedal edema? You know, listen to the femur. Do they have like what is not supposed to be there? Bruit in the femoral area region. Neuro-wise, what is the cranial nerves like? Any focal deficits? What is the mental status like? Another one you want to consider is white coat hypertension. People come into the office or clinics, the blood pressure is so high, but they go home, the blood pressure is normal. This is called white coat hypertension. People have that because of anxiety. You know, they get to a strange place they're not used to, or they're coming to the doctor, they don't know what the news they're going to hear. The blood pressure is elevated because they're panicking. Okay? But if the blood pressure is 140/90, like we said earlier, above 140/90, like we said earlier, that could be they have hypertension. Okay, so you want to do a workup on these patients to determine what could be causing blood pressure to be up, what could be the reason, you know. So you order urinalysis. You're looking for protein, you're looking for glucose. Protein should not be there. Then if the protein is escaping, what's wrong with the kidney? If the glucose is in the urine, what is wrong with the kidney? So you have to work them up and make sure they don't have kidney disease and diabetes. Okay. Another is microalbumin. You check microalbumin, albumin to creatinine ratio, 30 to 300 mics. It's microalbumin. That's a sign of kidney disease. Okay, and there is a cardiovascular risk as well. Check BMP, basic metabolic panel. I like to do BMP, and sometimes I may order a comprehensive metabolic panel depending on comorbidities, and they come back with all complex issues. You just want to check the kidneys, check the liver as well, just to figure out what's going on with this patient. You know, for BMP, you're looking at the creatinine. It's going to be elevated if they have like kidney issues. Creatinine is going to be elevated. You look at the GFR, so it will tell you if it's stage 1, stage 2, stage 3, stage 4 is end-stage renal failure. Oh, you know what I mean? So you look at that. Sometimes you have to consider dehydration. Some people, they are so dehydrated, the BUN is elevated, the creatinine is elevated, GFR is low. You hydrate them, it comes back up. So you want to pay attention too. Okay, look at the whole picture. All right. And glucose, as you're checking the BMP, look at the glucose. Is it high? Is it crazy high? Because it's not supposed to be that elevated. Okay. When you did the test, did the patient eat? Was it fasting? Those are the things you have to consider. Okay. But glucose should not be that elevated. Like greater than 130, that's an issue. Okay. If it's greater than 130, like even 110, it's elevated depending on the situation. It should not be that high. Potassium, is the potassium low? It may suggest hyperaldosteronism. I'm going to say that word again. Hyperaldosteronism. That's the one word that I always, stretch it when I talk about it. Hypertension. Are they on Lasix? Are they on any diuretics and they still have pedal edema? They have swelling in the legs. You want to rule out heart failure. You want to rule out heart failure. That means, could they have hyperaldosteronism because they're already on Lasix? For some, maybe they even have heart failure, they don't know. Or even if they already have hypertension and they're on Lasix and they're still swelling in the legs or diuretics, that's when you want to code them for secondary hyperaldosteronism. aldosteronism. This word is a catch-22 for me. So calcium, is it elevated? Do they have hyperparathyroidism? What about the hematocrit? Is it low? You know, when you check the CBC, you know, complete blood counts. Okay, is it low? Is it high? You do fasting lipid panel. Okay, if they have too much fat content, that can put them at risk for stroke or myocardial infarct, which is a heart attack. EKG is part of it. You can do EKG. EKG will show if they have left ventricular hypertrophy, which is it can be there because of long-standing hypertension, and if they have that, that's end organ damage. That means that blood pressure has been chronically elevated. Ischemic heart disease, that's another one. So the pre-existing conditions that be suspect to you when you see patient. Pre-existing conditions you have to watch out for. Do they have gout? Is the uric acid elevated? What about the PTH, hyperparathyroidism? Is the calcium elevated? Do they have osteoporosis, renal calculi, okay, which is kidney stone? Do they have that? They may be having hypertension. You may want to check, is it the secondary hypertension, you know? And if you do, another one is a macroalbumin. If the macroalbumin is greater than 300 mic, I will refer them to nephrology to start them earlier in the disease process. That is, if you do 24-hour urine collection and it's greater than 1 gram in 1 day, that's in 24 hours, send them to nephrologists, refer them so they can start treatment earlier. Okay. Echocardiogram, you check the heart valves. Okay, that will show too if they have left ventricular hypertrophy. Do they have arterial expansion? Do they have cardiomyopathy? Just check, you know. Do they have edema, like we just said? CHF. All right. Another is, we already talked about triple A, which is abdominal aortic aneurysm. And any aneurysm is not a good one, so you have to be careful when you see stuff like that. There's something called pheochromocytoma. That is, some people call it atopic kidney, adrenaline issue. When people have that, it's tumor they have in the stomach, somewhere in the stomach. They call it atopic kidney. If people have that, right, it makes the blood pressure go up so high, like they're almost like, it's kind of the blood pressure you see when people have hypertensive emergency. Okay, marked elevation of systolic and diastolic blood pressure. Okay, sometimes patient will tell you, oh, I ate something, I ate chocolate, I ate tyramine rich food, I drank wine, and my blood pressure went up so high. But sometimes it goes down. Sometimes they have palpitation, they are sweating so much, and they have this bad headache. So you may want to walk the patient up to see if it's a secondary hypertension. You treat the cause. If you treat the cause, most likely the blood pressure issue will resolve. Polycystic kidney disease, if they have that, you know how to help them. Do they need dialysis? Do they need surgery? So do they have a flank mass? Cushing disease, that's what I was saying, purple striae. Do they have Cushing disease or Cushing syndrome? Or are they on long-term steroid? That makes, like, if people are taking a steroid for a long time, it makes the body retain water. It causes edema and high blood glucose too. So their blood pressure is most likely going to be elevated. They will gain weight. So you want to pay attention to that. They may have central obesity, which is purple striae, like stretch mark. They may have like moon face and hump. They have a hump, We're gonna dive into that when we talk about endocrine. But right now, let's focus on blood pressure. I'm going off the track. So another one you want to watch out for the hyper elevated calcium, work them up for hyperparathyroidism, elevated creatinine. Do they have renal parenchymal disease, like chronic kidney disease? You know, another is, do they take drugs, cocaine, illicit drugs, over the counter decongestant, cough medicine? You're taking you see somebody that comes in, oh, my blood pressure is so high, it's so high, or you already diagnosed them with hypertension, but it's so they have a cold and the blood pressure is so high, like 180s and 150s, and what is going on? What did you take? Oh, I took over the counter cough medicine. If you look into it, you're gonna see they took a decongestant. It's most likely what caused their blood pressure to go up, and like a Sudafed, you know, they call it pseudoephedrine or phenylalanine, all those medications. You want to avoid them if you have heart disease. Okay. Let's talk about alcohol. People that drink, be careful, because alcohol can elevate your blood pressure. It causes a lot of issues, but we're not going to go into details with alcohol. When we do alcohol, like mental health, we'll talk about alcohol and what it can do to the body. Just know that too much alcohol is not good for you, for your heart either. It raises blood pressure. Sometimes it causes AFib. People have enlarged atrium. It can cause AFib, so be careful, okay? So that's all right. Let's talk about how to manage blood pressure. The big elephant in the room. I missed something. There's something I want to point out. In certain markets and in certain countries, there is medication that I see people come over here with. Like do you see them? They have high blood pressure, and I say, what medication are you taking? They say, oh, I'm taking this medication. I got it in my country. I don't want to mention any country. I don't want to mention any city. But if that medication starts with a bond, and if you add Derrick, now you sabi. So just think about, if you're taking a blood pressure medication and it has a bond, and if you add the Derrick to it, be careful with that medication. You may want to toss it. Okay? And talk to your doctor about it, about changing your medication, or find something else that will work for you if you're having problems with it. But that medication tends to, because it has high amounts of thiazide in it, with a little lisinopril. High amounts of thiazide can cause a whole lot of problems. Can cause elevated uric acid, gout. People come in with a lot of pain, joint pain. I hurt so much, I don't sleep well, I have pain, my toe hurts, my big toe hurts, you know. So just be careful, okay? Management for blood pressure. Number one is lifestyle changes. Everybody needs a little lifestyle change, including myself. Diet and exercise, stress reduction, low sodium diet, low saturated fat, avoid processed food, moderate alcohol consumption, smoking cessation. It helps a big deal when you have high blood pressure. If you can do all this, it's going to really help improve your blood pressure. Okay? Medication. There are a lot of blood pressure medication in the market, but I'm just going to touch a few. We will continue next time to talk. Next time I'm going to make video to talk more on blood pressure medication, okay? But I just want to talk to you about a few. Again, you can go to JNC8. I will refer you to that to get more details about blood pressure. So for blood pressure medication, there is thiazide, which is like the first line treatment. Thiazide diuretics, calcium channel blockers, ACA inhibitors, ARBs. These are class, you know, of hypertensive medication. These are the medications you can use. You can use them to treat hypertension. In hypertension, I tend to do what is called ratio profiling. That's what I want to call it, because not all blood pressure work for everybody. For non-blacks, white people, I noticed that ARBs tend to work more for them. Okay? Losartan is really good, but you want to consider the comorbidity, consider people's comorbidity, because you want to tailor their care according to their clinical presentation and their diagnosis and medical history. Okay? You can use thiazide or ACE inhibitors like lisinopril if they don't have allergy, or calcium channel blocker if they don't have heart block. Be careful with calcium channel blocker. Be very, very careful with that. You can use it in combination or alone. Losartan, like I said, it works well for white people. For black people, thiazide diuretics or calcium channel blocker alone or in combination works really well for black people. For chronic kidney disease, lisinopril is really good. Lisinopril is angiotensin converting enzyme inhibitor. It's very good if people have kidney disease. You can use herbs as well, but consider creatinine, GFR, creatinine clearance. You can calculate that by going to, you can do Crockford and go to Crockford. I'm going to put the links, and you can go there and plug in the BUN creatinine number, plug in the height, I think the height, the age, or something like that. It will give you the calculation. So it will give you estimated creatinine clearance. That will help you titrate the medication if you're going to put anybody on any medication. By the way, let's just say that any medication. Okay, so the goal for treatment for hypertension, you maximize what they already have if it's not going to cause a problem. Maximize what they have before you start adding a different blood pressure medication. So let's say they're on lisinopril. You started with the low dose, it's not working, and you increase it again, it's not working. Then you give them the max dose. If you have, you maximize that dose before you go to a different class. Like you want to add a calcium channel blocker. Okay, so you have to make sure that you already giving them or ordered maxed lisinopril, angiotensin converting enzyme inhibitor. Okay, so let's talk about, I just talked about thiazide diuretics. I'm supposed to talk about that, and I just went crazy. okay, so thiazide diuretics, let's talk about that. Okay, thiazide diuretics it's a medication that makes people urinate. It's a diuretic. Anything diuretic makes you urinate. So they give it to you. The way it works is that it decreases volume, and therefore it decreases preload. So volume decretion, that means you take it, you urinate, the blood, the water, you get rid of the water, then your blood pressure reduces. But this medication, like hydrochlorothiazide, is part of it. It can cause erectile dysfunction. That's the catch-22. Guys, this is for you. Erectile dysfunction, that means you can't get it up. You're trying to have sex with your wife or your girlfriend or whoever. You can't go up. You can't get it up. It may be the blood pressure medication that is causing that. Guess what? Don't stop that medication without talking to your doctor. Don't do it on your own. Let your doctor know that your blood pressure medication, you're taking it, but you cannot have sex with your wife anymore because you can't get it up. So they can work with you, find something that works for you. If you stop the medication just like that and you're not taking anything because it's affecting your sex life, you can have a stroke. You may be so uncontrolled that you can have a stroke or have MI or something, or heart failure. You don't want to do that. So this is just a warning. So look out for that, okay? If you're taking any blood pressure medication, or you're taking diuretics, thiazide diuretics, and this is happening to you, please talk to your doctor. Another is osteoporosis. Is actually good for people with osteoporosis, bone issues. I don't want to go there deeply. We're going to talk about osteoporosis when we get there, okay? But it helps if your patient does have osteoporosis and they have osteopenia. It's good to start them on this kind of medication, diuretics, thiazide, hydrochlorothiazide, okay? Because it's a calcium sparing. That's it. High dose, like I said, when I say bone, if you add Derek now you sabi, high dose of thiazide can cause gout. increases uric acid level. It causes joint, people coming with joint pain, my wrist hurt, my toe hurt, everything. Be careful, okay? You may want to look into why they're having that complaint. It can increase your glucose level, okay? It can increase the fat content, dyslipidemia, so be careful, okay? So if you are putting patient on this medication, thiazide diuretics, see the way I'm leaning, thiazide diuretics, you're gonna monitor them, right? You have to check the sodium, potassium, magnesium, because it can deplete those electrolytes, and those are important electrolytes, right? You don't want people to be walking around with low sodium and low calcium and all whatnot. If they have allergy to sulfur, do not give that. Sulfur allergy, do not give that, okay? My Niger people, listen to me. Not only Niger people, in fact, everybody, listen to me. Mostly in Africa, when you go to the doctor, make sure you tell them if you have allergy or you have taken a medication and you reacted to that. Let them know if they are giving you medication and you've taken that medication in the past. Oh, I took this medication. It made me my neck swell up. I couldn't breathe. I have rashes after I took that medication. Let them know, because you may have allergy to that medication, and make sure you know what you're taking. When you go to the doctor and they give you medication, know what you're taking. It's very important. It's very important, okay? All right, let's move on. Calcium channel blocker is another class of medication, antihypertensive. It's not a diuretic, okay? Mechanism of action, how it works is that it's a vasodilator. You take it, it relaxes the vessel. You understand? By relaxing the vessel, it drops your blood pressure, okay? It slows the heart rate. It's very potent, so be very, very careful. It's a very strong medication. It works really well for black people. So they have DHP, the one they call dihydropyridine. That's another big word, okay? So that is nifedipine, amlodipine. They act on smooth muscle. These medications, be careful, this class can cause pedal edema. Your patient is on it, you put the patient on it, they come back and say, oh, my legs are swelling up, I have edema. Don't panic. Look at the medication you ordered and see what you can do for them. Sometimes you want to give it with thiazide diuretics to combat this edema, okay? All right. So the other part of calcium channel blocker is non-DHP, non-dihydropyridine, verapamil. That's another one. It's very potent, very, very potent. They use it for rate control sometimes when people have arrhythmia. That's another topic. We'll get there when we get there, okay? But this medication can cause reflex tachycardia, so be very, very careful when you put patient on it, okay? And do not use if they have heart block. That is the source for lawsuits. If a patient have heart block, do not give them calcium channel blocker. Be very careful. It can cause bradycardia. It can cause CHF. Or if they have the CHF already, do not give it to them, okay? All right. So now you can take this medication, but don't take this medication with grapefruits, okay? React to it. Don't take it with macrolides. All the clinicians that are going to watch this video, you can't give this medication. I'm talking so fast because of the time. Yeah, we are now at 33 minutes. You cannot take this medication with macrolides, that's calcium channel blocker. They have two issues. They come in, they have infection, they have this. You cannot add macrolides to calcium channel blocker, okay? And it works well at night. So if you want to order it, you can put it at night, you know. Another is ACE inhibitors. What does it do? It blocks like conversion of angiotensin 1 to angiotensin 2, thereby reducing blood pressure, okay? Okay, so it's very good if they have diabetes or chronic kidney disease. At the same time, if their kidney is not doing very well, you titrate it down, or you can stop it entirely. It depends on the renal status, okay? It can cause hyperkalemia, and people, you put them on it and the patient comes in and say, I have this cough that won't go away. I have this hacking cough, my tongue is swelling up, my lips swelling up, I can't breathe. Please stop the medication right away and take care of this patient, because it can cause angioedema, it causes a cough, okay? And like I said, adjust the order according to the creatinine level, okay? Don't give it to pregnant women. If your patient comes in and say, oh, I'm pregnant, or I'm planning to be pregnant, please do see this medication. It causes birth defects. It's gonna hurt the baby. Okay? Alright. And do not give it to renal artery stenosis. I don't want to say they use it to diagnose renal artery stenosis, but don't give it to anybody with that, because it's gonna cause a big problem. Alright? So now let me see what else I have for you. Okay, I think that's it for today. That's it for today. And this, I budgeted only 15 minutes for this today, but I went over. And again, next time we're going to talk about other blood pressure medication. We'll talk about beta blocker. Okay, we'll talk about beta blocker and other ones. We're going to talk about clonidine and all those blood pressure. We'll talk about angina. All right, so angina is chest pain. Okay, so we will talk about that, and I want you to share, like, subscribe, comment. I'm reading the comments. Okay, guys, you take care now. Bye.